I'm Bert Garza, the academic vice president at Boston College. Among the privileges that I have as BC's academic vice president is to welcome scholars and other guests to events of this kind. Now, this event is especially gratifying to me, both as BC's academic vice president, but also because I'm a life scientist and a physician. As an AVP, I have to confess that it's a real joy to see students here at 9 o'clock on Saturday morning. I don't know how you pull that off, Melanie, but I think many of the faculty would like the formula for that. Congratulations. But especially when we have students and faculty come together with scholars from other institutions to wrestle with ideas, with complex problems, scientific information, but linked to a commitment to respect the individual and the communities that nourish each of us, as we have to do if we're going to be looking at ethical issues. Now, as a scientist and a physician, it's also a source of professional pride, because obviously this group values not only science, but those higher commitments that are embodied in ethical concerns. Seeing that linkage in young people is extremely exciting, because we often think that we have a choice between one or the other, and in fact they're not. They're not inseparable. Now, in thinking about the conference's major theme, the definitions of life, I thought a bit about an encyclical that Pope John XXIII wrote that I often come back to, because it is one of the wisest documents I think has ever been written. Now, I have to confess that John XXIII is among the heroes of my youth. A man who, for me, his life is a continuing witness to charity and joy and benignity and goodness and peace and patience, faith, mildness, and temperance, all those things that we value in our colleagues, we hope to find. I want to quote from that because I think it's especially relevant to this conference and to my welcome to you. And he says that since our present age is one of outstanding scientific and technical progress and excellence, one will not be able to work effectively from within unless she or he is scientifically competent, technically capable, and skilled in the practice of his or her profession. Now, most of us professionals would buy into that idea. But then he adds, we desire to call attention to the fact that scientific competency, technical capacity, and professional experience, although necessary, are not of themselves sufficient to elevate the relationships of human society to an order that is genuinely human. That is, to an order whose foundation is truth, whose measure and objective is justice, whose driving force is love, and whose method of attainment is freedom. Now, few of us would have imagined, I think that's a statement I can back up, it's empirical, I guess, but I think few of us would have imagined that mankind would have the blueprints within 50 years of that encyclical, not only for humans, but for multiple life forms. Don't think any of us were thinking that way when this encyclical was published. Now, the speed and the quality of scientific and technical progress that we have experienced since that encyclical has really been phenomenal by any standard. More than ever, I think we're going to be struggling, not necessarily with the facts we're going to learn, because facts can generally be neutral, but how we use them to fulfill our responsibility, professional and otherwise, and obligations to humanity. So welcome to the conference, and for each of your efforts to bring greater understanding to these growingly complex problems, I want to thank you, because this conference in many ways embodies the ideals of Boston College. So for that, my special thanks to the organizers and to each of you who are giving up some very valuable time to be here. Now, many of you will hear me say, if you've not heard me say already, that time is possibly one of the most valuable commodities I have, and I'm sure you as well. Never said this to a dean before. I don't know whether I would like for a dean to tell me this, but I always figured out a way I could get more money, get more space, be able to get more students in the lab. What I never figured out was how I could make more time. We all get 24 hours, whether it's the president of the university or an assistant professor. What we do with it makes a great difference. And so I want to thank Dean Hoffman for joining us today, because she's giving up that valuable commodity to be here with us. And for that, I'm very grateful. Dean Hoffman is the Associate Dean for Academic Programs and the Director for Law, Health, and Healthcare Program and at the University of Maryland School of Law, where she also is a professor. Now, she received her bachelor's degree magna cum laude from Duke University, her MS in Health and Management from the Harvard School of Public Health, and her JD from the Harvard Law School. After completing law school, she was an associate with the firm of Dewey and Ballantyne, but Palmer and Wood, I think that was correct, where she worked on legal issues in the areas of environment and food and drug law. Prior to law school, she worked as a policy analyst here in Massachusetts with the Secretary of Environmental Affairs. Had a distinguished career in a number of other areas in tobacco, and just has made enormous contributions to our better understanding of many of those issues. So Dean Hoffman, thank you for joining us, and the podium is yours.
Thank you and good morning. It's a pleasure to be here. I want to thank the organizers of the conference for inviting me today, and I especially wanted to thank Melanie McNally, because if the number of emails she sent me to get me here today is any indication of the number of emails she sent in total for this conference, I know she worked very hard to put it together, so thank you, Melanie. I also very much appreciated the invitation to come today, because it's given me an opportunity to explore a set of ideas that I've been mulling over for the last several months. And the impetus for those ideas were a number of articles that have appeared in the professional journals and periodicals and the lay press that have been very critical of our current framework, our laws and policies regarding decision-making at the end of life. And if I can figure this out, is there... How do I do this? Right. This is just one example of one of the articles. About a year ago, this article by Fagerlin and Schneider, Enough, the Failure of the Living Will, appeared in the Hastings Center report, and it caused quite a stir. It starts out, enough the living will has failed, and it's time to say so. And also in September of 2005, the President's Council on Bioethics issued a report on caregiving in America, and it concluded that living wills are a limited and flawed instrument. But the criticism has not been limited to living wills. It's been much broader, and it's touched on other aspects of our framework for end-of-life decision-making. And I initially, this was very troubling to me, because I worked in Maryland drafting our law that actually set in place the framework for end-of-life decision-making, particularly for individuals who lack decision-making capacity in Maryland. And it's pretty similar in every other state. But since I had worked on it, I was very troubled by these articles. And I initially thought, well, perhaps it's just an implementation issue. But then I wondered that maybe it's something more deep-seated. Maybe it actually goes to the theories and ethical principle underlying that framework, which is the principle of autonomy. So I began to look at the literature in more depth regarding what I can find out about what might have went wrong. And what I wanted to do this morning is share with you some of my findings and some of my thinking, starting with an understanding of how the current framework was developed, and then continuing to review some of the criticisms of those laws and policies and the underlying ethical framework. And then, and I think this is what's most challenging, I want to pose the question, if we agree that autonomy is not the right model, or at least not the right model for everyone, because I don't want to throw out the baby with the bathwater. I think that autonomy certainly does have a place, and many people are comfortable with the autonomy model. But if not autonomy for everybody, then what? Then what would we do differently? What policies and what framework would we put in place? It's easy to be critical. I think it's much more difficult to come up with a solution that's an improvement. So let me go back to the history. The early right-to-die cases came to the courts in the middle of the 1970s. And the posture of those cases was generally that you had patients or their family members on one side and healthcare providers on the other. Patients and family members, at least at that time, typically wanted to terminate life-sustaining treatment, and the healthcare providers typically wanted to continue. When the courts got those cases, they were in state courts, and the basis of the court's decision was primarily the doctrine of informed consent. The courts thinking that the corollary of informed consent is informed refusal, and that individuals should have a right to refuse unwanted medical treatment. But it's interesting, at the time, you may not believe this, but informed consent was still a relatively new concept in the medical profession. The initial court cases that really held that physicians had a duty to obtain informed consent from patients were occurring in the 1950s and spread over the next decade. And at that time, this was a very foreign concept to the medical profession. In fact, in his well-known work, The Silent World of Doctor and Patient, Jay Katz, who was a physician and on the faculty at Yale Medical School, said that disclosure and consent, except in the most rudimentary fashion, are obligations alien to medical thinking and practice. And so this was not something that the medical profession easily and quickly embraced. Before that time, physicians basically were the ones who knew what was right. They decided whether to disclose information about your diagnosis and prognosis. They didn't necessarily tell you about alternative treatment options or the risks and benefits of each of those. So it took, I think, both court cases, also a societal movement. In the 60s, we had many societal movements. We had the civil rights movement, the women's movement, the consumer movement. And one thing that kind of those movements had in common was questioning the current hierarchy, questioning those in power who were making decisions that affected others. And that included professionals and physicians. And also during the 60s, in 1965, Congress passed Medicare and Medicaid legislation. And that further, I think, repositioned patients as consumers who began to say, we want information about our health care and our health care treatment. So that pushed the legal court cases, and the societal movement did push the medical profession to adopt the doctrine of informed consent. And so it was somewhat of a natural progression that the courts would use this doctrine in the early cases on end-of-life care. It was fairly straightforward when they got cases where the patient had decision-making capacity, because then that person could give informed consent. It was a little bit more of a challenge when they got cases where the patient lacked decision-making capacity. They were unconscious, they had some form of dementia. Then the challenge to the courts was, well, how can they exercise their autonomy or give informed consent? But the courts rose to the challenge, and they said, well, these people generally have family members, next of kin. They can decide for the patient. They can decide what the patient would have wanted. They know them well. They can stand in the shoes of the patient and figure out whether this patient would have wanted life-sustaining treatment or not. That was something that the courts adopted, and it was a way to expand an individual's autonomy. Then state legislatures got in the act, and they also figured, well, we can also expand patients' autonomy through legal documents called advance directives, living wills, and durable powers of attorney for healthcare. They can you can execute one of these documents when you have decision-making capacity and say what you would like when if you become incompetent or unable to make decisions yourself. And we can follow that. So both of these mechanisms, advanced directives and family member decision-making called substituted judgment, was pretty much the framework for end-of-life decision-making for people who lack decision-making capacity. The assumptions underlying this model are that patients are both able and willing to tell us what they want when they become incapacitated. Are they going to want life-sustaining treatment if they're terminally ill, if they're in a persistent vegetative state, if they have advanced Alzheimer's? And they're going to tell their physician, or they're going to put it in writing through an advance directive. And if they don't have an advance directive, they'll be able and willing to articulate clearly to their family members what they would want. And the surrogate or family member will be able to carry out those wishes. And so this framework became part of medical practice, and it was adopted without much resistance. But there were some early critiques and some critiques that have continued to today. And I want to kind of describe those critiques in a little bit of detail. I think one of the first ones was what I call the feminist critique. You might also call it a caring critique, that argued that the autonomy model ignores family and relationships and the fact that we are dependent on others and often part of an interwoven fabric of people that we care about, and that their decisions affect us and our decisions affect them. The second critique, I call it the multiculturalism critique, goes that the autonomy paradigm is based on Western cultural values, and that we are part of a society where there are many cultures represented, and they don't all adopt the Western cultural model or Western cultural values. In an article on multiculturalism in medical decision-making, Alyssa Gordon describes, I think, this view about multiculturalism and the different perspectives of someone from a Western cultural and a non-Western cultural tradition. And I wanted to share that with you because I think it's a very apt description. She says, as reflected in the informed consent doctrine, the Western notion of autonomy favors the individual over the community, self-reliance over dependence, action over passivity, scientific rationality over spirituality, and forthrightness over harmony. An unequivocal emphasis on Western values in medical decision-making, however, erroneously assumes that all people approach health and illness in similar ways. It overlooks that in some non-Western cultures, individuals expect and desire that others will make decisions about their medical care, and that individuals do not want to receive information on which such decisions will ultimately be based. Persons identifying with non-Western cultures may be more spiritual, more family or community sensitive, or more tolerant of authority and social stratification. They may value decision-making processes that are less confrontational and defer more to physician discretion. A third critique I call the rationality critique, and that goes that the assumptions underlying the autonomy model, especially that all individuals make decisions rationally, that they kind of at arm's length, that they can accurately weigh the benefits and burdens of various alternatives and attach probabilities to those alternatives, kind of in a dispassionate way, understates the fact that many of us, when we make decisions, are influenced by emotional and social and cultural factors. And then there is a fourth critique emerging, and this is the one I'm going to spend the most time talking about. I think it's the most interesting. I call it the realism critique. You might call it an empirical critique. And it's based on the notion that the autonomy model does not really reflect the way that many people want to make decisions. That, in fact, they don't want the burden of these decisions or the responsibility, that they're overwhelmed by the information. And there are a number of studies that actually support this view from a number of different disciplines. So, for example, Bernice Pescasolito, who's a sociology professor, has said in an article on society and the balance of professional dominance and the patient autonomy in medical care that Systematic empirical research suggests that autonomy, the basic tenet of bioethics, stands contrary to patients' desires to shoulder that individualistic burden. Decisions are often too complicated, even for patients who consider themselves highly educated or intelligent. Also, Susan Chanak, who's a law professor, says that a rights model is not appropriate for end-of-life care. Empirical evidence regarding patient choice at the end of life suggests that individuals who are ill and weak may not want to make their own treatment decisions. But perhaps the leading proponent of this critique is Professor Carl Schneider, who's a law professor at the University of Michigan, who came out with a book called The Practice of Autonomy: Patients, Doctors, and Medical Decisions. And in the book, he amasses a considerable amount of empirical data supporting this view. He actually starts out his book by reacting to a view that he has observed in much of the bioethics literature that says that patients have a duty or obligation to make their own medical decisions. I call this the extreme autonomy model. And as an example, he quotes from one former law professor, a bioethicist, who says that if we are serious about patient autonomy and decision-making, we must render a patient's shifting of responsibility to the physician unacceptable. And we must insist that patients take primary responsibility for making decisions related to their health care. He also quotes from Dr. Timothy Quill and Howard Brody, a preeminent bioethicist, who have said that some patient-centered physicians have gone beyond encouraging patients to participate in medical decisions, forcing them to make decisions almost independently on the basis of neutrally presented statistics, as free as possible from the contaminating influences of physicians. He also brings forth some anecdotes from his own healthcare experience. This is Professor Schneider. And actually, one of them is about his own dental experience. He talks about going to his dentist, who he says informed him that he was a candidate for the delights of a root canal, and referred him to an endodontist. And he went to see the endodontist, and as he says, the endodontist did what endodontists do, and told him the facts of his case. And then he said, well, that's all well and good, that's all very nice, but do I need a root canal? And the endodontist said, well, that's your decision. And he said, yes, but I would be glad of a recommendation. And he says, well, I couldn't possibly give you a recommendation because your values about your teeth may not be the same as my values about my teeth, so that's your decision to make. So he, I think at that point, that might have been the motivation for him writing the book, but he does amass a great deal of empirical data and research on this issue about how patients make decisions. And I'm just going to share with you some of the studies that he cites in his book, because I think they're representative of some of the other ones. He begins with a study by Endy and colleagues. They presented 312 patients in a primary care clinic of a teaching hospital with a series of vignettes asking them about their preference for participating in healthcare decisions, and they changed the scenario a bit with respect to the illness and kind of increased the severity of the illness. And he asked them on a scale of 0 to 100, kind of there where 100 would be totally making the decision on one's own, and 0 would be basically deferring to the physician or not participating in the decision making. And on average, what he found was that their preference for decision making was quite low, 33.2 on the scale, and that as the serious of the illness increased, got more serious, they were less likely to want to participate in the decision making. He also cites a study by, before I get to that, the one thing he found, however, was that with respect to information, people did want information about their disease, about the treatment alternatives and risks and benefits. So even though they didn't want to participate in the decision necessarily, they did want information about their illness and treatment options. There you see the average score was 79.5. So he also cites a study by Kasseleth who gave patients, 256 cancer patients, a choice between two statements. The first was, I prefer to participate in decisions about my medical care and treatment, and the second was, I prefer to leave decisions about my medical care and treatment to my doctor. And then he categorized the responses based on the age of the research subjects. And as you can see, he found that for younger individuals, they very much prefer to make their own decisions. Then as it got to the more middle-aged group, still a significant majority wanted to make their decisions, but you had an increasing percentage who wanted to defer to their doctors. But then for those 60 and over, it was pretty much equal. Half of them wanted to participate in the decision-making, and half of them did not. Also, based on these studies and the others that are similar, he concludes that first, the elderly are less likely than the young to want to make their own medical decisions, and two, the graver the patient's illness, the less likely the patient is to want to make medical decisions. In addition to evidence about competent patients, he also cites two studies that indicate that some individuals, even who have executed an advance directive and said, and when I become incompetent, I don't want certain treatment, are willing to cede some of their autonomy to others. He cites a study by Segal et al. That appeared in the Journal of the American Medical Association, and he asked 150 dialysis patients how much leeway their physician and surrogate should have to override their advance directive if overriding were in the patient's best interest. And you can see the results are very varied. 39% said no leeway. They wanted their instructions strictly followed. 19% said a little leeway, 11% said a lot of leeway, 31% said complete leeway. After presenting this data, Schneider speculates as to why patients might not want to make their own medical decisions. And he comes up with a couple of hypotheses. These are two of them. First of all, they might not feel competent to make them, and second, they may be too sick to deliberate actively and well. And he focuses most of his attention on the first one, trying to think more about why they might not feel competent to make them. And he comes up with several suggestions here, having to do with medical decision-making in the medical system. First of all, he says that medical decisions are often shrouded in uncertainty, making it uncomfortable for patients to make those decisions. That lay people have difficulty with prognoses when they're expressed in terms of probabilities, and there's quite a bit of literature indicating that in the social science literature, people do have problems with probabilities, especially small probabilities. He says that doctors speak a different language, we might call it medicalese, that people have difficulty understanding, and that medicine is a bureaucracy with lots of different decision makers, and that even the most sophisticated and well-educated among us have difficulty navigating that system. Schneider then goes on to argue that physicians really are better decision makers when it comes to complex medical information. They have more experience and expertise because they've often seen many similar cases. They may have seen over 100 cases of breast cancer or Alzheimer's or certain kinds of diseases, whereas the patient and their family may have only seen one. They don't know what the disease trajectory will be or the course of the disease, whereas the doctor, because of his experience, is more likely to have seen, to be able to predict. That's not to indicate that the physician is always going to be correct, but this, on average, that they're more likely to be correct in terms of being able to predict the course of the disease. Also, he remarks that physicians are less likely to be emotionally involved in the case than the patients or family members, and that emotions can cloud one's decision-making. He also, I think, anticipates or tries to anticipate some of the response he's going to get to this kind of proposal that physicians should be making these decisions. He predicts that those proponents of autonomy would say, but these decisions really aren't medical decisions, they're value decisions. What he says in response is that the two are inextricably linked. You can't really disconnect the medical piece from the value piece. And then he goes on to talk about focusing on that value part, that making these decisions on the basis of values is really very difficult and not straightforward. And for many people, their values are, with respect to this issue, are unexplored and undeveloped, and that many patients lack considered religious or philosophical convictions, at least in a way that they would be able to translate those to specific healthcare or medical scenarios and apply those concepts. And even if they could, sometimes people's principles change with the experience of illness and treatment. A lot of times I think people think, especially younger people, if they would become disabled, they would not want to live in those circumstances. But what we find is that many people accommodate to their disability, and once they experience it, they would be much less likely not to want to be treated for other conditions. So what he concludes is that patients will often lack what autonomists too readily assume, a set of preferences which are clearly defined, well understood, and rank ordered so that people can make logical trade-offs among them. And then in making the point about the difficulty of making decisions based on values, Schneider also points to the literature on surrogates. This is also difficult for them, and that studies addressing the utility of the substituted judgment standard have documented substantial lack of accuracy in proxy determinations of patient preferences for care at the end of life under diverse clinical circumstances. So he amasses all this data. His book came out in 1998, but since then there have been a number of other studies coming up with similar conclusions, and there have been other articles, again, in the professional literature and the lay press. This article appeared last August in the New York Times. They did a series on patients and physicians and patient decision-making. The article, titled "Awash in Information, Patients Face a Lonely and Uncertain Road," described the difficulties and sometimes abandonment patients feel when forced to make decisions about medical treatment. It starts out with a story about Meg Gaines, who's a 39-year-old patient and mother of two with ovarian cancer that had metastasized to her liver. The first sentence reads, "Nothing Meg Gaines endured had prepared her for this moment. She was being asked to decide whether to undergo a novel chemotherapy regimen. 3 oncologists thought she should stick with the regimen. 2 other oncologists thought she should try cryosurgery first, injecting liquid nitrogen into the tumors to shrink as many as possible, and then following up with chemotherapy. The catch was that the chance of her even surviving the procedure was uncertain. Her doctor, according to the article, then recited what has become the maddening litany of medical correctness." And I'm quoting here, "We're in the outer regions of medical knowledge, and none of us knows what you should do. So you have to make the decision based on your own values." Ms. Gaines, bald, tumor-ridden, and exhausted from chemotherapy, was reeling. "I'm not a doctor," she shouted. "I'm a criminal defense attorney. How am I supposed to know?" The article goes on to say that as this new responsibility dawns on patients, some embrace it with a sense of pride and furious determination, but many find the job of being a modern patient with its slog through medical uncertainty to be lonely, frightening, and overwhelming. I think the social science literature that Professor Schneider and others have accumulated suggests a couple of different conclusions. That patients and their surrogates may not necessarily want autonomy, that they want help with their decision making, and they need and want the expertise of their physicians. To me, what this data implies is that the pendulum, perhaps, has swung too far in the direction of autonomy, back from the days of paternalism, and that perhaps it needs to swing back a little bit towards the center. Perhaps we need a new principle. Perhaps it's a combination of autonomy and beneficence. Perhaps we would call it benonomy or autoneficence. Something that would allow for more shared decision-making. But even if we agreed that we might want to change the principle, that still leaves the question, how would we change our policies and laws with respect to this? And as I said at the beginning, I don't think we want to throw out autonomy. I think we really need to realize, and what the data shows, is that people are comfortable with different models. We can't have a one-size-fits-all. We need something that accommodates various forms of decision making. But as I said, attempting maybe a little bit to be provocative, I don't think we always need changes to our laws to kind of change behavior. But I was trying to think, well, what would we change? What would we tweak if we could to try to accommodate this group of people who don't necessarily want to make decisions within an autonomy model? And I came up with a few things, and I wanted to share them with you and maybe get your reactions to them. It's interesting, actually, the first couple that I came up with, you might say, actually expand on autonomy. They allow people, through autonomous choice, to have their autonomy undermined. And let me explain what I mean by that. One thing we could do is to revise our advanced directive forms, kind of like the study that I cited before, where we give people a choice and say to them, you can check off that either you want your decisions strictly followed or that they should just be guidelines, and then defer to your surrogates or physicians saying that if you think something else would be in my best interest, that's fine. You should make the decision based on my best interest, not so much on what my preferences were. Interesting, the Veterans Administration hospital system is implementing this kind of choice in their advanced directives form. And I think Maryland may be the first state where currently our legislature is considering modifying our advanced directive form to include that type of choice. A second possibility, again, it does also build on this notion of expanding autonomy, but with a way to incorporate more beneficence, if you will, would be to make it easier for physicians to serve as healthcare agents. We actually could list in the law that physicians could serve as agents. The assumptions have been that agents would typically be family members or friends. And in fact, many states actually prohibit physicians from serving as healthcare agents. New York State, for example, says you can choose your physician as your proxy decision maker, but if you do, then they cannot also be your treating physician. So this, in some ways, kind of undermines patients who would really like their treating physician to continue to treat them and also make decisions for them. And I think I'd be very interested in your reactions to this. I'm also interested in kind of physician reactions to this, how comfortable they would feel with this kind of model. I mean, it's going back to the old days of the paternalistic model, but we've moved so far from that. Would physicians still feel comfortable in that role? A third possibility is that we actually list physicians and state laws typically have a hierarchy of who can make these decisions. Usually it's the spouse if you're married, your adult children if you have children, your parents if you don't have children or a spouse, your adult siblings. Maybe we put physicians somewhere in this list, and I think if we put them at the bottom, it may not be very controversial, but if we move them up, this would really be taking decisions away from family, and would be most likely physicians, if they knew the patient, would be able to incorporate the patient's values and preferences, but if not, it would really be a switch to a best interest model. The last option would be to give physicians the authority to make some types of decisions, to actually take it away from patients. For example, if family members were in conflict, the default could be the physician. Or even some kinds of decisions, we just say that patients don't decide this. Actually, Father John Paris, who teaches here at Boston College, has advocated that for seriously ill newborns who are very premature and where the prognosis is very dim, when we're talking about getting parental consent to withdraw life-sustaining treatment, that really shouldn't be given to parents because it's such an incredible burden and people really don't have a choice realistically in that situation or don't think that they do. So those are some of the things that I've come up with for how we might tweak the framework. There's one more option I wanted to discuss that doesn't actually involve a change in the law, and this is kind of my favorite, and it kind of goes to more of an institutional change or even a market model or entrepreneurial model, if you will. If we're serious about moving to shared decision making, one thing the law is not good at is getting people share decision making. It either says that the physicians make the decision or the patients make the decision, but it's very difficult for the law to kind of come up with a shared decision making model. Actually, recently I had some experience. My own father was hospitalized, and a few months ago, and my brother and my mother and I had to make decisions for him, including life-sustaining treatment decisions. And it became very clear to me that this type of professional could be very helpful to situations where families are where you have multiple doctors telling you different things, and you need someone to mediate between you and the healthcare providers, who often don't have a lot of time. They call you on rounds at 7 o'clock in the morning, and then they're seeing patients the rest of the day. And in the ICU, you can't turn your cell phone on, so you can't get a return phone call from them. So it's very difficult for patients and their family members to make decisions about complex medical issues. This person would represent the patient and the family. They would explain the clinical information. They would speak with different physicians. As I said, they'd kind of be a mediator or interface between the patient and the family and physician. And the goal would be shared decision making. It's a question about how we would implement this, whether this would be something that, who would pay for it, I think is a question, whether people would pay out of pocket, whether insurance would cover it, whether we should require hospitals and nursing homes to have on salary someone with this kind of background. I think there are a lot of things to explore about it, but I think it's something worth considering, as well as the other possible options if we really want to improve patient decision making in this area. And I'm open to your comments and questions. Thank you. Yes.
Hi, I'm a freshman in the School of Nursing right now, and it's very interesting to me. The professional that you described seems very similar to the training that we're receiving in the nursing profession, to be an interface between the family and the doctor. Obviously not necessarily as much of an advocate, but I'd be very interested. I would say that that could be a role easily fulfilled by a nurse, a registered nurse, or like a nursing professional.
Yes, I think either a nurse or a physician. It would have to be someone with a clinical background, but you would have to go into that role as your job, as opposed to, because what we found, I'm just speaking now from my own personal experience, nurses in the hospital, in the ICU, are very busy, and they don't have time necessarily to take on this role. But I think it could be a new profession for nurses as well. Yes.
I found your legal loss proposal very interesting, and I don't know anything about this field, but I would think that if you had a person, a professional, doing that, you would want to be leery of insurance companies paying them, because what if the insurance companies pressured for a cheaper option type thing? Because I know doctors right now, there's kind of some controversy about pharmaceutical companies giving doctors drugs to try out and taking them to dinner and doing stuff like that, whereas these drugs might not necessarily be in the patient's best interest, but the doctors keep prescribing them. I think you'd want to be a little bit careful of who pays that type of person to make sure that it's fair enough for the families and the patients.
It's a really good point. But I think what you have here is, I think, as I mentioned, starting off with a kind of a market model or entrepreneurial model, I think people would pay for this service. And some people would. But you always get, when you have something like this, then there are people that can't afford it. And do you, just want to make it available to the people who can afford it? One way to increase access and affordability is insurance coverage. Of course, then you have to worry about people who don't have insurance at all. So the third model that I mentioned, of whether you could convince a hospital or nursing home to have someone on their staff who's a full-time employee to do this, would be the other option. There, though, they have to be convinced that it's in their probably economic interest to hire someone like that. And hospitals certainly hired what's called discharge planners full-time, because their job is to move the patient out of the hospital quicker. And they're available all the time to talk to you about moving your family member outside of the hospital. So it might require something like JCHO accreditation or be a matter of licensing for nursing homes if you wanted to really push healthcare institutions to do something like this. Yes.
I just wanted to piggyback on the young nursing student's comment. I'm at the other end of the spectrum, being a nurse for 30 years, and the role is there. The clinical nurse specialist exists. And they have the clinical background as well as the academic knowledge to go into this role. The problem is it has to be valued from an administrative standpoint. Somebody at that level has to be willing to pay that salary for those nurses. It exists, it's there, they're prepared, they've got the background, but there has to be somebody, and I look at it, it's an administrative decision to say, yes, we're gonna spend this money to have this person in this role.
Right, well, that's just, I mean, you're just confirming what I said, that it's the issue of how do you get it into the system. And it may be something where it has to start with a market model that you have people getting paid and then the profession or the people who are doing this become known and its value becomes known. Yes?
I was interested in some of the results of a study that you presented in which, as the patients got older, their desire to be the primary decision maker got less. And I guess what I'm wondering is that a function of age? In the sense that no matter when the study was conducted, those who were older would have done the same thing? Or is that a function of culture in terms of generations?
Right, is it a generational matter or is it, actual age? I've been asked that question before and I haven't, it's hard to know because we haven't seen that generation, but it raises a good point. I suspect that it's really a combination about the intersection of the severity of illness and perhaps age. Those two things. I did share that one story from the newspaper about a fairly young woman, a 39-year-old with cancer, who was facing very difficult treatment decisions where the physicians had different opinions. And it seemed that she was feeling the same way, just totally overwhelmed with the information, and would have appreciated someone making the decision for her. So it may be the combination of those things, but it'll be interesting to see as the younger generations age whether they feel the same way. Yes.
Hi, I'm not a college student, I'm just here with my daughter, and I don't have any background in this. I can only speak to experience because my mother died of cancer. Her last wish was to die at home. I didn't know then, but I know now because my husband just went through with his father, but some physicians just don't want to let their patients go. And they just need to keep it simple because they gave her false hope that wasn't there, and I knew because I lived it. And I knew when my husband was ready to hear what he needed to hear. And the physician wasn't ready to let him go, and all he wanted to do was come home. And as a result of that, keeping that false hope alive with his wife, she made decisions based on him not being truthful with her. I knew what the next step was. She wanted to hold on to that last hope that wasn't there. And they talked when he was in the room as a third party, like he wasn't there. They weren't listening, and he died at a hospital. In a rehabilitation place, mind you, knowing he was dying, they sent him to a rehabilitation place. Because you know what? They didn't want to let him go, and they didn't want to do the right thing. Okay? And as a result, she has to live with the fact now, the last wish of her husband was to die at home. But because she had faith in the doctors that weren't being honest with her, she has to live with the fact that her husband's last wishes was to die at home, and he died in a rehabilitation when they knew he was never going to get better and he was never going to come home. My mother, fortunately, had hospice. You get hospice if you have 6 months or less to live, and they didn't even tell her that. He could have died at home. He could have died where he wanted to be in his home where he lived all his life. And he died in a hospital, which resulted in his family coming back and forth, day in and day out, from 7 o'clock in the morning to 8 o'clock at night, because they weren't being honest.
Right.
And it's not right. They just need
Right.
to keep it simple. And if they know their patients well enough, They know what's in here, and they need to listen.
I mean, you make some excellent, excellent points, and I think that's part of the criticism about the current framework that a lot of these efforts that have been tried in terms of surrogate decision making and even when you know what the patient would have wanted, they're not being implemented, they're not being followed. And again, I would hope that I mean, the assumption underlying those things is that the family members, like it's your father's wife, your mother, your father. I mean, they have they can be assertive enough to impose this, but it's very difficult for people in that situation. They
They couldn't be
They're-
assertive in this
right.
case though,
Yeah.
because she was trusting in what the doctor was
Right,
saying.
exactly.
Personally,
That's
the
part of
doctor
it.
wouldn't like it.
That's part of it, that you trust the physician and you're in this totally different environment where you don't really know, you're vulnerable, you have to trust them. And possibly if you had this kind of intermediary, they could stand up, they would have the clinical background, they could express the preference of the patients, they could represent the family member who's trying to tell them this is what the patient would have wanted. Thanks for sharing that, yeah.
In the policy of shared decision-making, what would happen to the patients who want complete autonomy over their decision-making and their responsibility for their own treatment?
I think that could still happen. I mean, it's not, that's, the shared decision-making model, I think, can stretch to both ends. It's kind of, I mean, you'd still need, certainly, whatever, even anybody who even wants to totally make their own decision, is going to probably want to know the medical facts. So at least they want that information. I mean, a lot of people now will go home and Google, about their diagnosis and their prognosis if they have a certain disease. They're not getting that information from their physician. I'm trying to help come up with additional ways we can improve that communication so that you're getting that. And even if you went home and Googled, you could still go back and ask your physician more questions about it. And people are doing that, yeah.
So does that mean, based on what you said about first the autonomy model and then some of the suggestions that you have, that any new development will be essentially built on top of the pre-existing autonomy model itself? Because we can't fully abandon that.
I don't think we can. I think that would be, I think we can abandon in certain circumstances, but there will always be people who are comfortable with that model, and it's just so much ingrained in our culture that I don't think it's realistic to move away from that, and nor would I advocate that we totally do, because again, I think that we want something that is not one size fits all, that has the flexibility to accommodate different views and desires about decision making. Yes.
We've been focused on the autonomy model in terms of the patient. And what are the legal constraints now on the medical profession in dealing with what you can say and what you can't say to patients and family members, and the restrictions you have in terms of practice? For example, in neonatal care, where in some states, if you don't do everything you can to save a child, then the physician is liable for battery and in fact be taken to court for child abuse.
Yeah, you're bringing up, I think that's pretty much the only restriction, I guess, that's in terms about where there's a limit. That already basically kind of takes decision-making out of the parents, but it also, in the sense, I guess, of the physician too, it's kind of a government model has come down and said you have to continue to treat these newborns under virtually all scenarios except for very, very narrow situations. That's part of the baby doe regulations, which are tied to federal law, the Child Abuse Prevention and Treatment Act, that says states can only receive funding for child abuse and prevention programs if they adopt in their child abuse and neglect laws a definition of medical neglect that incorporates the baby doe rules. And people have interpreted those rules in different ways, and I think some physicians interpret them fairly broadly. And because I think there is a lot of disagreement with them, and feeling that, especially because the technology has just, now we are able to keep newborns alive at 23 weeks. I was just talking to some neonatologists recently who said that yes, now, 5 years ago, the percentage of 23-week-old babies who were delivered, their probabilities of living was something like 10 or 15%. It's now up to 35%, but yet virtually all of them have very significant disabilities.
But in adult medicine, you don't see any changes in the legal framework if we move to something less than an autonomous model for the patient, or shared autonomy in terms of both legal obligations and liabilities.
Well, again, and at least what I'm proposing, you'd have, some of them, you'd have to have a change in the law, but they would, I mean, if you did something like change the hierarchy of who could make decisions for people who have no decision-making capacity, and put physicians at the top, I mean, that would require a change in the law, and so then you're dealing with, is that something that the public would support? I doubt it, that putting them at the top. But again, maybe further down the list, where you have, some states have more distant relatives deciding things that maybe those people don't really have an involvement or know the patient well. Yes?
I think the law is so complex, and in the spirit of keeping things simple, as suggested over here, I wonder if there's just an educational component as far as bedside manner of physicians and communicating with patients so that the decision is a shared decision without even changing the law.
Yeah, that's a good point. I think a lot of medical schools now are focusing on physician-patient communication. They're doing a lot more in terms of teaching medical students how important that is. It's also probably going to become more important just as a practical matter, because there are studies now showing that physician-patient communication is often a factor in medical malpractice suits and whether or not you're sued. And to the extent that that gets known, I think we'll have insurance companies, somebody who made the point, pressuring doctors to take communication courses if they're consistently sued. Thank you very much.